Hello friends, welcome back again to the Cortex YouTube channel. In the last video, I talked about basics of the beta receptor or beta blockers toxicity. Okay, beta receptors and how they act. So today we are going to discuss about the continuation of the same and starting with clinical features of the beta blocker overdose or toxicity. So beta blockers, they mainly have this cardiorespiratory symptoms. So this okay. So what are the cardiac clinical features cardiac related to cardiac system? So one thing, see beta blockers they reduce the heart rate, force of contraction. So thereby reducing the heart rate. That is your bradycardia. So bradycardia is seen. Bradycardia. Next, hypotension. Hypotension. So they also cause these conduction abnormalities like delay or dysarrhythmias, asystole. So conduction delay in conduction of the electrical activity in the heart, conduction delay, ventricular arrhythmias, dysarrhythmias, okay, and asystole. Okay, so decreased force of contraction, thereby reducing the stroke volume, thereby reducing the causing reduction in BP. So these are the cardiac symptoms and signs of the beta blocker toxicity. So what are the CNS toxicity? CNS toxicity are in the form of depressed mental status. Okay, depressed mental status, coma, psychosis, seizures, and respiratory arrest. And pulmonary complications or pulmonary symptoms are related to bronchospasm. So you will get bronchospasm. And biochemical metabolic parameters, you get hyperkalemia and possibly hypoglycemia or euglycemia. Most of the time it is euglycemia. Sometimes you may get hypoglycemia. So these symptoms they depend upon the which beta blocker, the type of beta blocker, or the pharmacological characteristic of the drug, like lipid solubility, and additional alpha and sodium channel blockade property. Okay, and the duration of action, whether a patient has consumed immediate release formulations or extended release formulations, IR or ER. So all these parameters influence the appearance of these clinical features, like your highly lipid soluble agents like propranolol, pindalol, penbutalol, timolol, and betaxolol. They are very highly lipid soluble, and they directly cross the blood brain barrier, and they cause CNS symptoms, more CNS symptoms, and rapid CNS symptoms. And these, since they are highly lipid soluble, they have volume of distribution, more volume of distribution, so they can't be hemodialyzed. Okay, they can't be removed extracorporeally by dialysis method. So these are all the parameters that will matter in the appearance of clinical features of the beta blocker toxicity. Okay, so I'll just mention here highly lipid soluble substances that you can remember by the help of this mnemonic PTB coma. They cause coma, no? So P means propranolol, P means pindolol, penbutalol. Okay, T means timolol, B means betaxolol, C means carvedilol. Okay, O means what? Oxprenolol. Then M means what? Metoprolol. A means it is acebutolol, not your atenolol. And okay, so these are the drugs which are highly highly lipid soluble. So first PTB are highly lipid soluble, and these are your moderate lipid soluble. So rest other beta blockers are your weak lipid soluble. So these lipid soluble, high to moderate lipid soluble drugs, they are absorbed rapidly since they are lipid soluble, and they cross the blood brain barrier readily, that is very easily, and they cause CNS symptoms like depressed mental status, coma, seizures, okay, delirium. All these are psychosis. These are all the CNS symptoms of possible beta blocker toxicity. So when to diagnose, how to diagnose, okay, how to diagnose a case of beta? It is very easy when there is clear cut evidence of history and examination, okay, but with the diagnosis becomes very challenging when there is polypharmacy or multiple drug overdose. So everyone has to have a keen a suspicion and keen observation on the patient history and examination findings. So if you do ECG in a possible case of beta blockers, you will get what is known as sinus bradycardia. Sinus bradycardia. Okay, this is one point. Second point, if this beta blocker has the property of additional sodium channel blockade, like your propranolol has a additional sodium channel blockade property, and your ismolol has the additional channel sodium channel blockade property, carvedilol, betaxolol, acebutolol. So these are the drugs which also have, so let me mention here, additional, along with beta blocker property, they have additional sodium channel blocking property. What are these drugs? Acebutolol, betaxolol, carvedilol, and propranolol. Don't forget this propranolol. So these drugs are having additional sodium channel blockade. So sodium is very important in the phase like one of the cardiac action potential cycle. Okay, so sodium influx is very important to have action potential. So this sodium channel is blockade, means what happens, there is widening of the there is increased duration of the action potential. So there is widening of the QRS complex. So you will get wide QRS complex, that is broad bradycardia, that is wide QRS bradycardia. So there will be bradycardia because of beta blockade property, and there is wide QRS because of wide QRS means what, more than 120 milliseconds, QRS duration more than 120 milliseconds. So one of the target to maintain is QRS duration less than 120 milliseconds. So one of the target of the treatment of beta blocker toxicity is your target maintenance of QRS less than 120 milliseconds. So this we have to remember, and this happens only when the beta blocker that is ingested has sodium channel blockade. Okay, don't remember that, don't forget that. And third thing, one important thing that you have to remember is about the sotalol. Sotalol. This sotalol has a very interesting property. You have to remember, please focus here. Sotalol has this potassium channel blockade. So this has potassium channel blockade. Okay, so those drugs which blocks the potassium channel, they cause prolonged QT, that is QT interval will be prolonged or increased. So you know what happens when there is prolonged QT, you get toxicities, D pontis, okay, ventricular from the premature ventricular complex. Sotalol causes premature ventricular cortex, premature ventricular complex, ventricular tachycardia, ventricular fibrillation, and toxicities, D pontis, and death. So this extra property or this special property of sotalol you have to remember. Okay, and see, that's what here you have to remember. So additionally, those drugs which causes prolonged QT, okay, already sotalol injection will cause prolonged QT. In addition to that, if you are giving any drug like for example antiemetic ondansetron, Okay, androstenedione will also cause prolonged QT. So two drugs causing prolonged QT, patient will definitely going to die. So before giving androstenedione in cases of beta blocker toxicity, why I'll tell you in the treatment part why you have to give antiemetics. So okay, so that I will tell you in the treatment part. So you better know this. Okay, one point. So you remember this point. This is a special point about sotalol. So it is worth repeating. Sotalol, potassium channel blockade, prolonged QT, possible ventricular dysarrhythmias and death. So if you, this is about ECG that you have to take bedside. Okay, if you do blood test and lab parameters, what all they will show, you have to do all the routine blood tests. And if you do glucose, serum glucose or blood glucose, it will be most of the time there will be euglycemia. Okay, but what can be expected is hypoglycemia because of the blockade of glycogenolysis. Okay, hypoglycemia can be expected, though it is theoretically common, but it is in practice it is uncommon. Okay, it's uncommon. Next, if you see the potassium, it will be elevated, hyperkalemia, and you have to do RFT in all the cases and ABG in all the cases. Okay, this is very important. And you have sometimes tox screen urine toxicological screen, sometimes it may show amphetamine positivity because this labetalol, if the patient has ingested labetalol, the metabolite of labetalol has a structural similarity between amphetamine. So amphetamine may come positive whenever you do tox screen, urine tox screen, when the patient has consumed or ingested labetalol in a overdose. Okay, so this you have to remember. This is false positive amphetamine, false positive, because of the metabolite of the labetalol. This I thought worth mentioning, so here I mentioned here. And sometimes you get drug induced Brugada pattern. Drug induced Brugada pattern in cases of propranolol ingestion in a overdose, excess dose. So this is about the lab parameters and ECG. So what are your DDs that you have to consider in cases of beta blocker toxicity? See, one of the very closest differential diagnosis is your calcium channel blocker. Why? Because it will also cause decrease in heart rate. It will also cause BP, that is negative inotropic and negative chronotropic activity, that is bradycardia and hypertension. So how to differentiate? Here? The CCB is characteristically associated with elevated lactate level, that is lactic acidosis and hyperglycemia. Okay. So CCBs are characteristically associated with hyperglycemia, while beta blockers are hypoglycemia or euglycemia. Okay, lactic acidosis is seen in calcium channel blockers. One more differential diagnosis is your OP poisoning. OP poisoning will also cause bradycardia, hypertension, but there is characteristic OP toxidrome symptoms like sweating, defecation, urination, all that, lacrimation. Okay. Next, one more differential diagnosis is clonidine poisoning. So clonidine poisoning, it has this meiosis, like opioid symptoms, opioid poisoning like symptoms, meiosis. So here you should know the toxic compounds causing meiosis. That poisoning, where all you see meiosis. You remember a simple mnemonic OP compound. You see characteristically in OP compound poisoning row, pinpoint people, that is meiosis. So you remember OP compound poisoning, OPC. O stands for, as you know, it is opioid. O also stands for organophosphate compounds. P stands for phenylephrine. P also stands for pontine hemorrhage. C stands for clonidine, as discussed just now. So these are the possible 1, 2, 3, 4, 5. So these are the 5 possible causes of meiosis, toxic causes of meiosis. Okay, hope you find this information useful. Okay, so these are the possible differential diagnosis. Okay, now we'll discuss about the proper treatment aspect. Okay,